Hello, good afternoon, good morning, or good evening from the World Health Organization headquarters in Geneva. It's Wednesday, and we are again having a Q&A on COVID-19. Our experts are answering your questions. Last week, we had a shout out from Dr. Mike Ryan to Women in Science. So today I'm actually accompanied by two women who are scientists, Dr. Maria Van Kerkhove as usual, and Dr. Soumya Swaminathan, our chief scientist. So please ask your questions as usual on Twitter using the hashtag AskWHO, and on other platforms, please leave your questions via comments section. Before we receive questions, I would like to reflect on this positive note and shout out that Mike gave last week to Women in Science, maybe on your career and highlight in your professional development and work now as women who are scientists on COVID-19.
Thank you, Alex. So I am a medical doctor and a researcher from India. I've spent most of my life doing research on HIV and TB, the two other infectious diseases. And I've done a lot of work on clinical trials, but also a lot of work in the community, and recognized that scientists, sometimes we tend to be so interested in our own work or so preoccupied that we are not always thinking about what the results of our research mean, how to translate them quickly, how communities perceive them. And over my career, I've now learned the value of having a dialogue with the participants, both with patients who are part of clinical research, but also communities where we do the research. And that's been really a valuable learning for me. And I think in COVID-19 as well, that's what we're trying to do. We're trying to involve civil society, patient groups in understanding what their values and preferences are, what their points of view are, and trying to build our research around that and with them.
Thank you, Dr. Soumya. Maria, what is your story and highlights in your scientific career as a woman?
Thanks, Alex. So I'm so pleased to be with Dr. Soumya today, and I'm an infectious disease epidemiologist originally from the U.S. I've been living abroad for about 16 years now or so. My background is in infectious diseases and emerging pathogens, mainly respiratory pathogens, so influenza. I spent a lot of time in the field. I spent a few years in Cambodia, where we were working on this area of work called One Health before it was even called One Health. It was the human health, it was the animal sector, and it was where people live, where animals and humans come together. And doing a lot of investigations and studies around these very rare pathogens that spill over from animals to humans, and doing studies to understand why that's happening, where that's happening, the extent to which the virus has reached the human population, and working with communities, just as you've pointed out, the value of working with communities and really understanding how we are so connected with nature and with animals. And most of my career I've been working with high-threat pathogens, so that can spread rapidly once they enter the human population. So not only influenza, but also Zika and dengue. And I've been working on MERS, coronavirus, since 2012, when we first learned of that virus that emerged in the Middle East. And it's really, my interest in my work has mostly been around outbreak investigation, so at the time of the spillover, and what we need to do to prepare for that when it does happen, the types of research that needs to be done, and then developing prevention and control programs. So it's led us well to where we are right now.
It's really a great pleasure to have women leading this response together with other experts, and with all the rich experience that you're bringing from different fields and different countries, and not just from WHO. Moving to COVID-19, the issue that has been raised this week, and we received some questions, was about those so-called lockdown measures. Maybe you could clarify once again. I know we've spoke about this in press conferences and in different interviews, but maybe for our social media viewers as well. What is WHO? Can you please explain that? Does WHO actually recommend lockdown measures? And is this measure effective? And when countries are using it?
Yeah, so maybe I can start. So I think we need to start with the word lockdown and what lockdown actually means, because for many people it means many different things. And actually the word lockdown, we don't use that word. If people listen to us, you hear us sometimes say so-called lockdown measures, because it's a combination of factors. Some of this means stay-at-home orders. Some of this means movement restrictions. Some people think a complete closure of all businesses, workplaces, schools, public transport. And so it means different things to different people. Our position, and we've been talking about this for quite some time, we've even included it in our strategic preparedness and response plan where we've talked about this. We haven't recommended the use of so-called lockdowns. What we've recommended is a comprehensive approach in all of these different measures that need to be taken. You hear us say do it all, but it's the individual measures that people take with the physical distancing, hand hygiene, respiratory etiquette, wearing a mask, staying at home if you're unwell. It's an all of society, all of government approach with having strong surveillance and active case finding, contact tracing, making sure that we have trained clinicians and we have good clinical care. I could go on and on. It's all of those measures. But we do recognize that some countries in some areas have had to use what is called so-called lockdown measures because they needed to buy themselves some time to build up the system to be able to carry out all of those activities. And if we remember back in the beginning of this pandemic, many countries who did have experience with similar pathogens like SARS, like MERS, like avian influenza, knew how important public health infrastructure is, and they activated that immediately, and they were able to handle things a lot faster and in a more aggressive manner. And other countries who didn't have that experience really were caught off guard. And cases increased rapidly. Health systems were very overwhelmed very, very quickly. And many countries had no choice but to impose these stay-at-home measures and these more restrictive measures. And so while we've never recommended the use of lockdown, what we do is we support governments in their approach to control COVID. And so we advise, and we continue to advise, to use all of the tools that we have at hand. And it really starts with the active case finding and contact tracing. And arguably, one of the most important things that countries can do, that individuals can do, is if you are identified as a case, that you remain isolated in a medical facility or at home if you can't be in a medical facility, and that contacts are identified and that they are quarantined. These are things that are really critical to break chains of transmission. So there's a lot that we can do. So thanks for asking the question to clarify, but I think the use of that word lockdown really means so many different things. We're very, very hopeful that countries will not need to enact these again, and we are seeing countries demonstrate with the data they have, with the knowledge that they have, the experience that they have, that their interventions are much more targeted. They're much more tailored to very specific geographic regions. They're much smaller, they're not national, and they're time-bound, and they're limited, and they're focused on where they really need to be used.
Thank you.
If I can just add
Please.
to that, absolutely everything that Maria said, and the targeted approach, understanding the disease and the epidemiology, knowing where the virus is, and also we know much more about where these viruses can spread. What are the situations? The closed, crowded settings, the indoor spaces with poor ventilation. Here we have all our doors and windows open. We're maintaining physical distancing. Everyone can't do that. So if you're in that situation, you need to be masked. You need to be doing your hand washing. So I think engaging communities is perhaps something that needs to be done much more. And local administration, public health authorities who've engaged communities have been able to find solutions and implement them.
Thank you very much. This was very good explanation of what does it mean as a lockdown, so-called lockdown measure, but also what countries and what we can do. Unfortunately, in recent days, we had new records of number of cases globally. However, the mortality rates are not growing that fast. How come is that happening? Do we have any news on the treatment of patients?
So I can start. The first thing I'd say is that mortality rate increases always lag behind the increase in cases by a couple of weeks. We know that. So if we see a huge increase in cases as we're seeing now, unfortunately that might be followed by increasing deaths in a couple of weeks. Having said that, from the beginning of the pandemic to now, certainly there's been a decrease in case fatality rates, absolutely. And that's for many reasons. One of the reasons is that doctors around the world have learnt to treat this disease better. People are getting diagnosed at an earlier stage, because at the beginning we didn't have enough diagnostic tests. Only the very sick, those who presented to hospitals, were getting tested. Now there's much wider testing. So you're picking up people at early stages, you can follow them up, make sure that they're not getting sick, monitor their oxygen levels, and so on. And then the progress we've made on treatment, because of all the randomized clinical trials that have been happening, have told us which drugs work, which don't work. When should you give oxygen? At what stage should you put people on mechanical ventilation? Dexamethasone is a good example. It's an old drug. It's been used by doctors for a long time to treat many diseases. But it was a randomized trial which really confirmed that dexamethasone reduces mortality by about a third in people who are ventilated, so the very, very severely critically ill, and by about 20% in those who are on oxygen but not on ventilation. And it also showed that for the group of people who have mild disease, who do not need any respiratory support, the dexamethasone doesn't help and could even be a little harmful. And this is why randomized trials are important, because for an individual doctor, their own clinical experience teaches them a lot, but it's, after all, only one person's experience. And you might be seeing a particular profile of patients. But when you do randomized trials and you have a group of people treated with one intervention or a drug and another group of people who are given all the standard of care but accept that one particular drug, then you are really able to compare both the benefits as well as the potential risks and side effects. So those kind of things have made sure that doctors are actually, once people are in hospital, taking care of them much better. There's also been a changing age profile. From the beginning of the pandemic, we've seen the mean age of infection coming down. And perhaps young people are out more than older people who are still, protecting themselves by staying indoors. And that could be another reason why the case fatality rates have come down. But I would end by saying that it's still far too many. We're still losing approximately 5,000 people a day to this disease, and those are all preventable deaths. So we shouldn't be complacent that death rates are coming down.
Thank you very much. We're already receiving a lot of questions, so I'll start reading some of those. The first one is from a LinkedIn viewer. Are all data on COVID-19 considered accurate? And how do we check the accuracy of data?
That's a great question. Certainly not all data everywhere is accurate, but there are a lot of systems in place that are trying to capture different types of data to help us understand this pandemic. There's surveillance data that all countries are looking at. It's their active case finding, who is a case and who is not. And a lot of that comes from the testing that is being done. And as we've pointed out, the testing capacity has increased dramatically since the beginning of this pandemic all over the world. And we have new tests that are online where test results can come back quicker. And so there are reporting systems where that happens. Through WHO, through the international health regulations, we have a data reporting mechanism by which our member states report cases to us. And this is why we have our dashboard. So we pull information from sources, confirmed sources of those cases, but also of deaths. But there are a number of other types of sources of information, how we monitor circulation. We utilize the GISRIS, the Global Influenza and Surveillance Network, that has existed for 70 years. And that's where we look for community transmission. And so what this uses is samples that are collected from individuals who have influenza-like illness or who show up in hospital and have severe acute respiratory illness. Those are tested for flu, but they're also tested for COVID-19 as well. And so we can determine if there are cases being detected in the community through that. There are studies that are done. There are clinical studies in hospitals where we look at different types of data from patients. This is where we capture information about underlying conditions. What are the underlying conditions that people have? What are the underlying conditions that make someone more at risk of developing severe disease and death? These are the things like cardiovascular disease, chronic respiratory disease, obesity, diabetes, immunosuppression, many different factors, age. We collect information about symptoms. What are the signs and symptoms? associated with COVID-19? How do those differ from flu and from the common cold or from other diseases, from dengue, from malaria? And so we're always learning. And so you sometimes hear us update our information on signs and symptoms. Well, for example, a loss of taste or loss of smell that some people had. That comes from studies that are being done in different countries that report to us and say, this is something that we've noticed in the patient data. And there's so many other sources of information and data that come from us. But they're not all high quality, but there are systems in place that check. And it's very challenging to be able to capture this much information on a global scale every day. So we have these dashboards that we use, and we try to release the information in real time. But that is the result of hundreds of thousands, if not millions of people that are working with patients, that are working in labs, that are working in database management and trying to pull different sources of information, consolidating that, analyzing that, and reporting that. So it's a lot of sources of information. I'm only giving you a fraction of the types of information that we collect. We also gather information and data, if you will, from our international networks. So you've heard me and Soumya talk a lot about our international networks, because as the Secretariat, as WHO, we have a convening power that we bring people together. We have all these international networks, clinical management, for example, meeting together where we have doctors and nurses and medical professionals talking to each other about how they are treating patients, what they are seeing in their patients, the clinical trials that they are carrying out, and that exchange of information and data gets incorporated into our guidance and our advice that we give to the public. So it's so many different sources, but as an organization, we need to make sure and verify the information that we receive, because the guidance and that we put out is for billions of people globally. So it's important that we check, and we check the accuracy of that before we use it, to make sure that we use it appropriately.
Thank you very much. We have a next question coming as well from a viewer on LinkedIn. When health systems are overburdened and families need to take care of a COVID-19 patient, can WHO and other bodies specify a set of do's and don'ts, including medicines to buy on a day-by-day basis as the virus progresses in an infected person?
So I think the question is about managing somebody at home who's
yes.
infected. And the first thing is, it wouldn't be a good idea for the family members to go and buy drugs and give it to the patient. So the best thing is really to be in touch with a healthcare provider, local healthcare provider. But it's true that a lot of COVID infections are mild, and the person needs to be kept comfortable, of course, isolated if possible, so that the rest of the family members don't get infected. If there's no facilities for isolation within the home, then it's much better that the person gets admitted to an isolation facility, so that you're protecting the rest of the family members. They need to be given a nutritious diet, plenty of fluids, paracetamol if there's fever or body ache, and it's important to keep a watch on the symptoms. And if at any time, if there's increasing difficulty in breathing, if the person is feeling unwell, is unable to eat, is feeling faint, then it's best to go to the hospital and not try to self-medicate at home. Many local authorities and local governments now have actually health workers that once you inform them that there's somebody who's positive, they will actually check on you either by phone or through an app, or may even come home. I've seen in some countries they come home and check your breathing, your pulse, your oxygen levels with a portable pulse oximeter. So it's best to be connected with a healthcare provider.
If I can just add to that, so we have issued some guidance on home care.
Mm-hmm.
So our advice is that if you test positive for COVID-19, that you're cared for in a medical facility. Now, we realize that that's not possible globally with so many cases that we are seeing, but it is important that if you are in a high-risk group, if you are over 60, if you have any underlying conditions, that you are cared for in a medical facility. And the reason for that is because you are at a higher risk of developing severe disease and of death. And so we want to make sure that those individuals, if you have to prioritize who's in hospital, it's individuals that are at a higher risk. And of course, anyone that shows up that is visibly ill and needs to be admitted to hospital. If you can't be admitted to a hospital, we have guidance on how you can be cared for at home. But we need to recognize that if someone is infected with COVID-19, with the SARS-CoV-2 virus, and they're put at home and they're cared for at home, there's the possibility that the virus will spread within the household. Most transmission is actually still happening in households. This we knew from the beginning, from the outbreaks that were detected in China. And one of the most important things that they did in China was recognizing this and then isolating individuals who were infected outside of the home. And that is actually happening in other countries as well. And if that can happen, if you're at home, isolate an individual in a single bedroom if possible. And again, we know that that's not possible in many situations because there's many people that live in homes, there might be multi-generational homes, but keep distance from others because the virus needs to be in close contact with other people. Make sure that there's disinfection that's happening at home. Make sure that there's good ventilation, open the windows, good natural ventilation, that the person at home wears a mask, a medical mask. Those that are caring for that individual, try to keep it to a minimum of one person if possible, wear a mask as well. There's a lot of things that need to be done if an infected individual is at home, but they can be cared for safely. I just want to highlight that knowing that someone is not cared for in a medical facility, there's the possibility that they may transmit to others. And I think there's a responsibility that we all have to support individuals. The other thing I just want to highlight are community health workers. We've seen in so many countries utilizing this incredible workforce of mostly women, but men as well, who are out there visiting people's homes, checking on them, making sure that they're doing okay, taking their temperature, checking their oxygen in some situations, just checking in. And this workforce of millions are doing an incredible service because someone who is sick, who doesn't necessarily need a hospital bed for COVID, but it also frees up beds for other diseases that are circulating for people that need care. Community health workers are heroes. Absolute heroes, and community health workers are not new for COVID-19. These are people who have been working for decades in many countries, and who are really keeping people alive. So we just want to give a shout out to community health workers all over. And volunteers, and in languages, making sure that the local languages are there with refugees and with expats who are working outside of their homes. It's a wonderful thing to see.
Thank you very much. Here is another question coming as a follow-up to the first question on so-called lockdowns. We did, from our Facebook viewer, we did not shut down or lock down when we had SARS or H1N1, and we have lived our lives amongst the virus, and there was no lockdown. So why do we need to have these measures now?
So that's a really great question. So in some countries, they've used lockdowns because the systems got overwhelmed so quickly. And in many situations, it wasn't just case numbers that were increasing, but it was hospitalizations. And so hospitals were full. All the beds were full, the ICUs were full, healthcare workers were overwhelmed, and governments needed to buy some time. And by doing so, that alleviated some of the pressure on the health systems. And that was a measure that was temporarily in place, that was used. Recognizing how much of an impact that has had on economies, on livelihoods, on people's mental health, on children, because schools were closed as well, we're finding the balance now. And so what countries are doing is they're lifting these lockdowns. And the challenge of implementing lockdowns is you have to lift them, but you have to lift them slowly. Because if you lift them all at once, you can have a resurgence and become quickly overwhelmed again. So what countries are doing, they're using this phased approach where it's slow, it's staggered, it's data-driven, it's not all at once all over a country. They've opened up different parts of countries, where transmission was less intense, started to open up and maybe have 25% of the workforce back, for example. And so using that, they've been able to lift those. But what is unique about COVID-19 And it was the same for the first SARS virus. This virus is controllable. And the reason we keep saying that is because in many countries, they're showing us that it is possible. If you look at many countries across Asia right now, in fact, many countries who didn't impose a lockdown, they used all of the tools that they had in place. They have been able to keep the virus low. Look at Cambodia, look at Thailand, look at Vietnam, look at Laos, look at Australia and New Zealand and China and Japan. And although some of them have had some resurgence, those have been in clusters and they've been in outbreaks. Again, using the tools at hand, bring those outbreaks and those clusters under control.
Thank you very much, Maria. We are receiving a lot of questions about treatment, vaccine. So maybe Dr. Soumya, you can tell us more about the updates on under Solidarity trial on treatments, but as well, where are we with vaccine candidates?
Sure. So the Solidarity trial, as you know, was a multi-country adaptive trial. What it means is that you can test multiple drugs against a common standard of care arm. So when we launched this at the end of March, the drugs that were prioritized at that time were hydroxychloroquine, lopinavir, ritonavir, which is an anti-HIV drug, remdesivir, which is a repurposed antiviral drug, and interferon. And so the expert group decided that those were the drugs that needed to be tested. And so we started the trial. Today, the trial is ongoing in about 30 countries, over 500 hospitals, and hundreds of doctors are participating in it. The first interim results of the trial will be published very soon. So it's in the final stages of analysis. And so that will give us a good idea about this first set of drugs. And then we're looking at what next. We're looking at monoclonal antibodies. We're looking at immunomodulators, at some of the newer antiviral drugs that have been developed in the last few months. So this is a wonderful global collaboration. It's established a platform. And I think this is one of the things probably it's a good thing that's happened during this pandemic, that preparations for research, the investments that were made over the last couple of years, having learned from the Ebola outbreaks and other outbreaks, people realize that once you're in an emergency situation, it's hard to set up research unless you've planned beforehand. Mm-hmm. And because that planning had been done, investigators knew how to write protocols quickly. People were sharing ideas, round the clock. Everything was done very quickly. Ethics committees responded very quickly. The manufacturers of these drugs, the developers, they came forward. They donated the drugs for the trial. So it was all in all, I think, a good experience. And similarly for the vaccines, I think we can learn from this experience. So we're hoping that we can have a similar solidarity platform where as new vaccine candidates come in and finish phase 2, they can actually get tested in the solidarity platform, because we have sites, as I said, in all regions of the world. And the key advantage we found is that as the epidemic is going down in one part of the world, it's still raging somewhere else. Mm-hmm. And so you can keep testing what you're doing. A single country trial is limited sometimes by the fact that you do a good job of controlling the infection, and then you don't have many more cases to run clinical trials with. So this is one example where global collaboration is very helpful. I can say more about vaccines if you'd like
Please.
Me to.
There are questions coming.
Can I say something before you go
Sure.
to vaccine? I just want to also acknowledge, like you just highlighted, all of the work that happened before this pandemic. The RDR Blueprint was set up several years ago. We had been talking about high threat pathogens. MERS was one of those. SARS was one of those, and Disease X was one. Disease X is the next virus, and it could be a coronavirus, it could be an arbovirus, we don't know what it is. But the work that was done, particularly for MERS, I want to highlight, because those researchers, there were clinical trials that were underway looking at lopinavir and ritonavir, looking at monoclonal antibodies, and there was a network of clinicians who were talking and who had protocols that were underway. Those protocols that were being those clinical trials that were being run in Saudi Arabia, for example, the Miracle trial, that protocol was shared with colleagues in China and said, this is what we're doing, this is how we've approached it, here's the protocol that we've used. That exchange of information happened in the first few weeks in early January, but that's built upon relationships over many, many years. And in fact, everyone's working on COVID-19 now, but it's a very small world where researchers come together, and there is a camaraderie and a solidarity amongst scientists and professionals who really want to get the answer. You know and for MERS, it was very difficult because we had so few cases, and we still have so few cases. And MERS has not gone away, but we had so few cases, and so being able to exchange the information and the value of the Solidarity Trial to have a multi-site study and principal investigators at hospitals in how many countries?
30 countries currently, but another 15 or so waiting to come on board.
So that's really incredible, and I don't know if we've expressed that enough of how amazing that actually is in the middle of a pandemic. You know, when people are really focusing on getting through their days, to be able to have high quality clinical trials with enough patients to get that answer is really incredible. And we can do it faster, and we're working to do it faster. But in fact, this is quite rapid. But I just wanted to say that it's built upon the work prior to this pandemic. And I'm hopeful that the work that we're doing now will help us in the next one, which I hopefully won't be for a very long time. But we're very grateful to all of our research partners and professional partners all over the world. Sorry, you're going to
trials take years and years.
Yeah.
I'm used to working in tuberculosis. You know, sometimes you're waiting 7-8 years for a trial to be completed and results to come out. Here we're looking at 6 months, you know, and even that we're impatient. When are the results going to come out? Similarly for vaccines, you know, it takes a minimum of 5 years to develop a vaccine. And again, I must say that it's all the investments that have gone into developing the platform technologies, getting ready for this pathogen X, this disease X, the so-called thing which could appear anytime. That investment has paid off because there were platforms that were ready to go. And as soon as they saw the whole genome sequence of the SARS-CoV-2 virus, on January 11th, scientists started developing new vaccines, and by March, the first human trials had started. All of that is unprecedented, and it's amazing how science is, you know, really delivered this time. So now we're in a situation where we have over 40 vaccines in some phases of clinical development out of over 200 candidates, you know, in the lab, and we have about 10 or 11 of them that are in the late stages, what we call phase 3. So we're very excited, looking forward to seeing the results, but we can be optimistic, but till we see the results of the phase 3 trials, we don't know which and how many of those vaccines are going to be safe and effective and protective for a long period of time. So this is something that we'll probably start seeing in the beginning of 2021, and then it goes through a process of regulatory approval. The data is submitted to the regulators. The WHO has also put out an expression of interest. We're asking developers of vaccines to get in touch with us, to submit their data to us so that we're up to speed, and we will do everything possible to do the guidelines and the regulations as soon as possible, but without compromising on the data. Because I think, you know, these are vaccines that are going to be given to billions of people, not even millions. And so we need to be absolutely confident that it's the right thing to do.
Yeah, and it doesn't. And just to say to the viewers, it doesn't mean we compromise on safety. So it is, even though this is happening very, very rapidly, there is no skipping steps on safety and efficacy. That needs to be perfectly clear. And this is why these processes are in place. And this is why it does take some time, because you have to go through those phase 3 trials where there are many more people who are enrolled in those clinical trials. And it takes time to get those results, because you're not only looking at if the vaccine works and provides some protection, but you're also looking at health outcomes. So you're looking at for adverse effects and for many different things to ensure that if we vaccinate billions of people, that we're not putting people at risk. So I just want to be very clear, we are not compromising on safety.
Thank you very much. Just a follow-up question. Once we have, hopefully, the vaccine that is ready and safe for use, do we have any plans on distribution strategy? Dr. Soumya, you mentioned that it will be given to billions, but I assume we won't have billions of doses ready immediately. So what's the plan?
That's right. I think that's a very important point, because people tend to think, on the 1st of January or the 1st of April, I'm going to get the vaccine, and then things will be back to normal. It's not going to work like that, because no one has ever produced vaccines in these volumes that are going to be needed. So in 2021, hopefully we will have vaccines, but they'll be in limited quantities. And so we worked on, a framework for how you would prioritize, how countries would prioritize to whom they would give those vaccines. Let's say country X with a population of 100 million people got 5 million vaccines. Who are those 5 million, or rather, 2.5 million, because most of these vaccines are 2-dose vaccines. I think most people agree that the people at highest risk of both transmission, getting the disease and getting sick from it, are healthcare workers, frontline workers, and then the elderly and the vulnerable. So the WHO has a group called the Strategic Advisory Group of Experts on Immunization, the SAGE. They've just come out with a very nice document on how to look at this problem, how countries can look at it, and use the framework that they've provided and look at their own demographic profile, their own epidemiological data, and say, well, in our country, we think these are the people at highest risk, and so they should be the ones who get it first. Next would come this lot of people, and then this. Most people agree that, it's starting with healthcare workers and frontline workers, but even there you need to define which of them are at highest risk, and then the elderly and so on. So then once we get to the point, so this is very, it's important for countries to now start preparing, to start having these guidelines, to do the training, to look at how vaccines will be delivered through the health system. Are they going to be through facilities? Are they going to be through campaigns or community-based approaches? And then when the vaccines start coming one by one, when the results start coming, then the same group, the SAGE, will make recommendations on every specific vaccine. So they'll say this vaccine can be used in this age group, so many doses, this is the storage conditions, this is what it should be used for, and this is how long we think it'll be protective. So there'll be a lot of guidance coming out. This is a lot of details to work out, but I think for an average person, a healthy young person, might have to wait till 2022 to get a vaccine, but by that time, hopefully we can stem the acute impacts, reduce mortality, protect those who are at highest risk, start solving the acute problems, and then we start by go into protecting the larger percentage of the population. And people talk about herd immunity. We should only talk about it in the context of a vaccine. So once we have a vaccine, we can aim to have population immunity, herd immunity, because you need to vaccinate at least 70% of people. You need to have them protected to really break the transmission and sort of.
Can I couple 2 points? One is to say, you said when the vaccine will be ready. There may be more than one vaccine. You hear us say a lot that there are a lot of candidates that are in, as Sumi just described. So the more candidates we have, the better the opportunities we have to succeed. And so there may not be one vaccine, there may be many vaccines, or we're hopeful that there will be many vaccines. And that will increase our ability to produce. And at the same time as the vaccines are being developed, the discussion around production is happening already. And that normally doesn't happen. You normally wait till you get the results and then you start production. But we're doing this at the same time because we know we need so many doses so quickly to focus on the high-risk workers. And you hear us say a lot that what we're aiming towards with this allocation framework is that we have enough vaccine to vaccinate those most vulnerable, most at risk in every country, as opposed to having vaccine for everyone in a couple of countries. And that's really, really critical. We need to make sure that we vaccinate those most at risk in every country before we vaccinate everyone in a couple of countries. And I think part of that is not only due to the commitments of governments, but also the understanding of individuals. And saying, I'm a younger person, I don't have any underlying conditions, I may need to wait so my grandparents can get a vaccine, or so my husband or wife who is as a health worker can be vaccinated. And I think we need to understand that, and we're working with many different groups to explain what vaccines are, what they can, what they can't do. And there are people who are already afraid of a vaccine that we don't have yet. So what is the reason for that? Where is that coming from? And how can we work through that to better explain what vaccines are and how they can help? But as Soumya has said, and as you've heard us say every time we speak, we have tools right now that work. We have tools right now that can prevent amplification events. We know that this virus needs people. They need people in close contact with one another. We are seeing super spreading events, which is how this virus operates, it's how it spreads. Those can be prevented right now with all of the measures that we've put in place. So if we continue to do that, we can get ahead of the virus. And in many countries, they've controlled transmission. So we need to do both. So while there's incredible advancement in therapeutics and in vaccines, there's incredible understanding in how we can use tools right now to be able to bring transmission under control and to save lives.
Thank you very much, Maria. And Dr. Soumya, of course. Here's a follow-up question because you mentioned community workers. So our viewers are asking, what is WHO doing to make sure community health workers have appropriate and sufficient personal protective equipment?
This is a fantastic question. So first of all, we need to make sure that health workers are wearing the right PPE and have access to the right personal protective equipment. Any health worker that is screening for COVID patients or visiting homes where there may be COVID patients needs to be in the right personal protective equipment. This includes a medical mask. If they have any interaction with a patient, it includes what we call droplet and contact precautions, which is a medical mask, eye protection, a gown, and gloves. And if there are certain medical procedures where you can have aerosol generating procedures, they need to be in airborne precautions. But it's good to say that. We just need to make sure that there are ample supplies that are in the hands and are being worn by those community health workers and all health workers. So we've worked with many partners to increase production capacity of gowns, gloves, eye protection, medical masks, and not only that, but in many countries, so that it's not only set in 1 or 2 or 3 countries, making sure that production increases, but also making sure that it's able to be shipped to countries where it's needed most. And so we worked with many partners to box these up, get them on planes. And if people remember, and in many parts of the world, the airline industry has shut down. So we've worked with WFP, we've worked with many different groups to get these supplies into the hands. In addition to that, we've worked on training materials to make sure that the materials are put on and taken off. We could don and doff appropriately and safely to make sure that not only do you have them, but you wear them at the right times, that they're worn, that they're fit appropriately, especially if you wear respirators. If you're in, you need to have what we call a fit test, and so they need to make sure that they adhere properly, and different types of trainings. So there are online trainings that we have through our Open WHO platform, and those are in, I don't actually know how many languages are.
I think it's over 40 languages, or 41 languages, I think, that we have courses for COVID-19 so far.
And so making sure that those training materials are translated into different languages means we can reach more health workers where health workers are working. And we have them in high bandwidth. We also have them in low bandwidth because we know internet access is not the same globally. So there's trainings, it's the materials, and it's making sure that we have people have access to those. But it's not completely fixed. We have not solved the supply problem. It was a completely broken system at the beginning of this pandemic, and many people have worked very hard to increase that capacity, but it still isn't fixed. There are still many health workers all over the world who do not have access to appropriate PPE. And we have many health workers who are considering or who need to reuse materials, who are looking at different ways that they can reuse materials that are only meant for single use, and that is unacceptable. So we, as WHO, will continue to work with our partners to be able to ensure that health workers all over the world have access to the life-saving materials that they need.
Thank you very much, Maria. I know that we are running out of time. There were a lot of questions, and we tried to answer as many as possible. But before we close, we spoke about vaccines, and many people are asking when we'll be ready, and we answer some of those questions. But while we're waiting for a vaccine, we still have tools that we can use now to fight this virus. Could you maybe explain or repeat what is this set of tools that countries and that we as individuals can do now to stop COVID-19 transmission?
Sure. Well, we have tools for governments and leaders who are decision makers who set the policies in place in terms of having an all of government, all of society approach you hear us talk about, because this is beyond health. So we need to make sure that the policies that are put in place help people actually carry those out. We have individual measures, advice to individuals on what they can do to protect themselves and to protect their loved ones. This is physical distancing. And again, you notice we keep saying physical distancing and not social distancing, because we need people to remain socially connected with one another and utilizing the technology that we have to keep our mental health and our well-being fit while staying physically distant from each other. We have hand hygiene. Hand soap and water, alcohol-based rub, respiratory etiquette, sneezing into your elbow, wearing of masks. We have being informed. One of the most important things people can do is be informed about where is the virus circulating around them and what do I need to do. I set a task at I think it was the last Facebook, and I hope users took that seriously. Know what you need to do if you think you have COVID-19. If you think you may be infected or you may have come in contact, what are the steps that you need to do? Who do you need to call? How do you get a test? What is your plan? I think that's really, really quite critical. It's staying home if you're unwell, calling your medical provider to see what do I need to do, where do I get a test. It's following local advice and being patient with that, because local advice changes as the situation changes, and being patient with that. And I look at our posters all over, which I love, which I don't know if the viewers can see, but be vigilant, be wise, be alert. Know all of the measures that you can do to prevent yourself from being exposed. Avoid closed settings, crowded spaces, especially in closed areas where there's poor ventilation. If you're indoors, open the window. I mean, those are simple things that can be done. Making sure that if you use air conditioning, you don't use the recycle, you get fresh air that comes in from outside. There's lots of things that we can do. And we can support our health workers. So if you're asked to stay home, please stay home. If you're able to work from home, work from home. There are many industries where you can, and production can keep going. But there are many professions where you can't.
Thank you very much, Maria. And just to reflect, tomorrow is World Hand Washing Day, and this is one of the main measures to prevent infections in general, not only COVID-19. And we've been asking health workers and everyone to clean their hands often, if not with the soap and water, then with hand sanitizer. But it's one of the measures that we can keep each other safe. I thank you very much for your time today. It was a pleasure to have two women scientists today, and I thank all our viewers watching us from Nepal, India, Netherlands, Pakistan, Vietnam, Venezuela, Cambodia, Liberia, the United Kingdom, Philippines, Italy, the United States, Somalia, Dominican Republic, Bangladesh, Gabon, Canada, Guatemala, France, Czech Republic, Saudi Arabia, Tanzania, Germany, South Africa, Brazil, Mexico, Portugal, Malaysia, and many, many others. The list is always very long, so we really thank you for your attention every Wednesday and any other day when our colleagues are sharing the updates on COVID-19 or on other health issues, how to protect yourself and your loved ones. Until next Wednesday, please stay with us, follow our social media channels and our website for more information. Thank you.